Hi, welcome to CT Chest Review at www.ctchestreview.com. A little longer wait, but I think it's worth it. So, 24th snippet, the radiologist's role in pulmonary hypertension. So, what is pH defined as? Elevated pressures in the pulmonary arteries and sometimes veins, and PAP greater than 20. In the West, most people get wedge pressure catheter studies done. In India, we typically do everything on echo. So, can we on CT scans diagnose pH? And there was this paper from the Fleischner Society which talked about these cutoffs. And I typically use 32 millimeters because the population we have usually have some form of interstitial lung disease or COPD. And you can see a typical patient here with UIP, IPF, and MPA of 33 millimeters, where I will say in the report that there is likely pulmonary hypertension. The PA to AA ratio doesn't work in our elderly patients most of the times because most of them have ascending aorta dilatation, and so this fails, and the raw diameter is perhaps the most important. Now, the lower the diameter, so if you use 29 millimeters, then it's likely you won't miss any patient with PH, but about half will be overdiagnosed. And if you use 34 millimeters, again, we won't miss any patient who has PH, or rather, every time we say that there's PH, we'll be right. But we will miss a certain number of patients. And so, 32 is a decent compromise where almost all the times in patients who have some diffuse lung disease, a 32 millimeter diameter suggests pH. Having said that, we don't need to split hairs, just mention the diameter and leave it, because the physicians are not really interested in our CT diagnosis of PH. So we should mention it as part of the report in diffuse lung diseases, but otherwise it's fine. Our job is to find the cause, and we have this 5-group classification which originally started as the Dana Point method, and now it's just called the 5-group classification. And there are various ways that people depict them, and it's gotten more complicated with more and more additions, etc. But a good way to do that is keeping it simple. Group 1 is idiopathic, what we used to call primary pulmonary hypertension. Group 2 is left heart disease of all kinds. Group 3 is all your diffuse lung diseases. 4 is CTEPD, so all your chronic thromboembolic disease, hypertension. And group 5 is a whole bunch of miscellaneous. For us, the important thing is fibrosing mediastinitis. Now, we have no role to play in group 2, and I'll tell you why we have no role to play predominantly in group 3 as well. And so we need to focus on the other groups where we can make a difference. And so our job is to pick up the ones that cannot be diagnosed clinically. Like this 37-year-old, echo done showed pH of 90, referred for CTPA. We see a mosaic pattern. The white areas show large vessels, the black areas show fewer vessels. Then obviously we have to look at the expiratory images. And the great part here is we don't see air trapping. So even the areas that are black become gray on the expiratory images. Not all of them, most of them. And that's your sign that this is mosaic perfusion, that this is not air trapping. So it's not small airways disease. Clearly, there's no interstitial lung disease. This is therefore the mosaic perfusion off. And we're coming to the diagnosis. Complete occlusion on the CTPA of the lower lobe branch of the RPA. There are webs, there are stenoses. So we've got those here. We've got bronchial artery collaterals that are prominent, and that adds on here. The MPA diameter is fine, but the RV is dilated. There's reflux into the IVC, so we've got all of that as well. And since we have a dual energy scanner, there's marked perfusion defects throughout the lungs, and that's added on here. Now, this combination of findings is characteristic of chronic thromboembolic pulmonary hypertension, and this is while VQ scanning would also give us the diagnosis, this is a CT scan diagnosis. Remember that it occurs in 2 to 4% of acute PE survivors. All patients with with post-thrombotic deposits would be said to have CTE-PD, and then if they have PH, it becomes CTE-PH. VQ is the gold standard. DCT is good, but not easily available. And a negative CTPH does not rule out CTE-PH because you may miss distal disease, and these are the two types of vascular lesions. Now, the signs are the ones we've already mentioned, where we have filling defects, abrupt tapering, occlusion, intimal irregularity, webs, bands, stenoses, etc. RV changes are your indirect signs, and your MPA diameter being high. Now here we've taken 29 millimeters as a cutoff, so that's fine for CTEPH and bronchial artery collaterals, and then the mosaic perfusion as parenchymal changes. So direct vascular, indirect vascular, and parenchymal changes. And here's another patient, and we had discussed this case in CT chest review. You can see the mosaic perfusion defects, MPA, RV dilatation, bronchial artery collaterals, and fibrotic occlusion of the LPA. So this is one group where we as radiologists make a difference. The second is here, 26-year-old progressive dyspnea, severe PH. These are the lung findings. Clearly the MPA, RP, LPA are dilated, but there's no mosaic perfusion. And then when we did the CTPA, we found that, but we also found the cause, and we'll come to that. If you've picked it up on this, great. If not, then here is where we are. This is the right superior pulmonary vein draining directly into the SVC. These are the dilated RPA, LPA, and here the MIPS show the shunt very well. This had been missed on 3 prior CTPAs, and I did a post on ctchestreview.com to just ask, why do we as radiologists miss these when that's literally our job? You have a patient who's come with PH for a CTPA. You're supposed to look for shunts. You're supposed to scroll up and down and look for them, and that's when you'll find them. It also happens with MR. This patient was sent as suspected ARVC, dilated RV. We always do a QPQS, which, as you can see here with the absolute stroke volume, is almost 3:0 or 3:1. And we found this right superior pulmonary vein draining into the SVC with a sinus venosus ASD. So this is the second condition, shunts, where we make a difference. The third is these patients. Now, this patient has a dilated MPA, a child. You've got these ill-defined centrilobular nodules, but no clinical evidence of an interstitial lung disease. This is a pattern that we get with either PVOD or PCH, where you have these subtle areas of microhemorrhages. Typically, that's what they say is the cause of all these areas of ground glass. And you have a BMPR2 mutation that can also present in this manner. PVOD is pulmonary veno-occlusive disease, and PCH is pulmonary capillary hemangiomatosis. They're all part of the same spectrum of diseases, and they often have pleural effusions, septal thickening, and these findings. Here's another patient, again, 26-year-old, no shunts, no CTEPH, otherwise normal heart. You've got MPA and RV dilatation. You have all these perivascular areas of ground glass suggesting group 1 PH. So we can make that suggestion depending on what we find on the CT. Then we have this group. You see this patient here had a pleural effusion. Gradually the left hemithorax is showing reduced volume. And that's because there is this ill-defined lesion occluding the LPA at its origin. And this is classic fibrosing mediastinitis. These patients, there were other structures involved. You get a dysplastic lung over a period of time because there's no blood supply. There's no pulmonary arterial supply. Everything now just depends upon the bronchial artery circulation. So there's no gas exchange. The lung is not participating in that. And this is a classic dysplastic lung that you see with these findings. So this is our job in patients with PH to pick up conditions that cannot be diagnosed clinically or by other means. Now, what about diffuse lung diseases? I grade it out because you'll say, obviously in patients who have COPD, ILDs, post tuberculosis lung disease, we make a difference, right? We can look at the MPA diameter and pick it up, but that's done clinically. The patient presents with respiratory disease, you know the patient has diffuse lung disease, the patient will get an echo done. We do document the MPA diameter, but we are not making a difference in the pickup of the pH, right? So these are these three conditions. I mean, here is a patient who has obvious MPA dilatation, the RV is dilated, and the patient has non-smoking COPD, post-tuberculosis lung disease or PTLD, extensive volume loss in the upper lobes, fibrocalcific lesions, patchy air trapping, all of this put together. We don't make a difference. I mean, this is all to document the findings, but the pH diagnosis is clinical and on echo. Or this patient who has UIP, IPF, and pH, or this patient who has severe smoking related advanced destructive emphysema, also has PTLD and pH with a 34 millimeter diameter with a PA to AA ratio greater than 1. So we should document, but it's not our primary job. And so that's where I come to. This is the difference we make. Picking up CTE, PD, CTE, PH or group 4 disease, shunts, group 2, PAH as a suggestion, and fibrosing mediastinitis in group 5, and in diffuse lung diseases we kind of just add value by documenting the MPA diameter. So our primary job is to identify conditions not easily diagnosable clinically that can cause or associated with pH and identify them, and secondarily, in all CT chests that we read, if we have an MPA greater than 32 millimeters, especially in diffuse lung diseases, we should document the findings. Don't forget the table of contents. We have extensive material up there. That's my WhatsApp channel to keep track of things. For those of you like other sites and cases, this is what I did about 10 days ago and why this is now important. That's my Atmasvas book. This was the CT biopsy case, almost now 4 weeks old. This is the BST case that I put up about 3 weeks ago. And this is the new thing that I've started, the YouTube case of the day, which you can subscribe to so that you'll just see it when you open YouTube in your subscriptions. And I put up a case every day of a case that I've reported or seen that day. You know where to comment, email, subscribe, and thank you so much for viewing this and listening to me.